All right, thank you. I'd like to thank the moderators for the chance to come and talk about this, and to all of you for coming to listen to it. I don't have any financial disclosures. Probably the only relevant disclosure to this talk is early in my career, I did a lot of endoluminal reflux treatment. Now I do not. So whether that colors this talk or not is up to you to decide, okay? I do probably still spend an irrational amount of my life thinking about it. So there you go. All right. So the question I've been posed with is, will the use of endoluminal reflux therapies increase over time? If you asked me that in 2009, I would have put one slide up there that said yes and then walked off, right? But now I think we have to think a lot about, well, where have we been? Where are we trying to go? And can pure endoscopic approaches take us there? So we've been looking at this, therapeutic gap figure for a long time. And so we have this large group of people who have breakthrough symptoms on PPIs, but they don't want to have surgery because of side effects, and we're trying to fill that gap. And we haven't made that as much progress as we'd like with that over the last 20 years. So when we're thinking about this, who are we going to target when we're thinking about, can we use endoscopic therapies? So patients who need the best acid control, esophagitis, strictures, Barrett's, these things, that is not who we're targeting here, right? We've got patients who they want to improve their quality of life, whether they have breakthrough symptoms or they have intolerant to PPIs, or patients who just have these concerns about long-term PPI use, whether or not the data is actually supporting that those effects are real. People are very concerned about it, primary care doctors are very concerned about it, and people want to be free of their PPI. So these are the patients who we're thinking about. So then the question is, do the treatments actually achieve the goals that we're trying to when we sit with our patient in clinic and talk about what our goals are, will these procedures actually achieve those things? So when we look back, we've had a lot of endoscopic tools in our toolkit over time. So injectables were first, then radiofrequency ablation, which I think had some attention for a period of time, but is largely been shown not to be durable and effective and isn't done as much anymore. Endoscopic mucosal resection with or without suturing is a newer approach, the same thing. And then suturing. So the EndoCinch was a single fire device. This is the endoplicator. This actually was you could do multiple firings, but you had to pass it multiple times. And then our current most common fixation device is the Esophax device, or TIF, where you can do multiple fires of fasteners. What do all of these things have in common? They are all LES-focused, treatments. So all we're doing is trying to reinforce or boost the musculature of the LES to try to prevent reflux. When we look at the outcomes of this, they're pretty disparate if you break down all the outcomes, but what's pretty consistent is that, one, the outcomes are very tightly correlated to patient selection. So in 2009 and 10, we had the privilege at Ohio State to try to apply TIF to a more expanded indication. The results were not good. So you have to stay very much within the indications we were talking about. The PPI cessation rate, if you look at dose reduction, you see reports up to that 80% at 1 year, but if you actually drill down into the cessation data, the durable PPI cessation rate with pure endoscopic therapies isn't very high. So for people who are concerned about taking PPIs, it's dubious whether the current treatments can do that. They do tend to improve quality of life scores. So if your patients just want their quality of life to be better and they're okay with the idea that they might require a PPI, whether it's at a lesser dose or the same, but they will feel better, these procedures can achieve that and do it fairly often. And then finally, they really are associated with lower rates of bloating and gas, and we're going to talk about that in a second. All right, so our limitations. So patient selection is more challenging than it seems, right? So we want patients who don't have severe esophagitis and they have an intact crural diaphragm, so their problem really is just a valve problem. That's actually not that common of a situation, and it's harder to assess preoperatively than we think. So here's a patient, she had a normal esophagram, she's got a pretty normal looking endoscopy, But when we went to do surgery, sorry, this picture's a little fuzzy, but you can see like her hiatus, she doesn't have a obvious hernia, but she's got a hiatus that is quite, it's loose, right? So I think the crural repair here is an important component of her reflux control that we're just not addressing if we decided to do a TIF in the GI lab for her. How do we sort of look at this? So we don't have real good data yet on how could we improve what happens with endoscopic therapy if we also close the hiatus. And kind of the closest thing we have is the experience with LINX and doing sphincter augmentation. Is when this device came out, we said, okay, we don't need to do all this hiatal closure and everything. We're just going to put this ring around the LES and it's going to fix the problem. And it did for a lot of people, but the PPI recidivism rate at just 1 year was over 16%. If you close the crus, it drops to 3.6. And this basically explains the gap between what we see with endoscopic therapies and fundoplication. So I think that it sort of underscores the point. The advantages, like we said, less bloating, less gas issues, because I think the reason for this is this is another thing I spend too much time thinking about, is we lose the ability to accommodate gas in the stomach because the fundus that we're using to create that fundoplication is the part of the stomach that accommodates air, and you don't feel bloated because it sits there. We take that away, so people feel much more bloated and gassy because they can't deal with that. There's good data for this in the pediatric literature, not so much in adults. Endoluminal therapies do have some potential in altered gastric and anatomic conditions. Data is limited. The argument will be made that they're easier to standardize. I would say that's questionable because the more complicated these procedures get, again, they become harder to standardize. Just a quick word about hybrid approaches. So CTIF has emerged as an idea, right? Fix the hiatal hernia, desufflate, do your TIF. As a surgeon, I struggle with this because if I'm sitting there looking at it, why would I then abandon that view and do an endoscopic procedure when I can do with my hands and some stitches whatever I want to do? There are studies that are showing better reflux control, preserved lower bloating and side effects. And so we need long-term studies. We need direct prospective comparisons to really understand what those differences are, but that's something to look at and keep an eye on. So in conclusion, so will reflux endoscopic therapies be more common? It's like a solid maybe, right? So without improvements in our diagnostics, we're gonna have a hard time identifying. We wanna say, we know that a certain percentage of patients will do better with this, so it could be an option, but we have to be able to identify them first. The hybrid approaches, I think there's two ways this could go. One is they could prove to be valuable and lead to more use. I think it's more likely that if we see better side effects, it may inform how we think about surgical correction of the valve and change the way we think about doing the operations rather than switching back to endoscopy. And then finally, until we figure out a better way to prevent hiatal recurrences, none of this is going to work because almost all of the redo operations we see are because of recurrent hernias that are either symptomatic because of failure of the fundoplication or because of a hernia in the setting of an intact fundoplication. So I think one of our speakers is going to talk about that later, so we should all listen close. Thank you very much.